Well, hello everyone, and we are here to discuss our roundtable tomorrow, which is for tomorrow. My name is Jalesh Panicker. I'm a neurologist, and we have Marcus Drake, who's a professor of neurological urology, and Dr. Sanjay Sinha, who is a urologist with special interest in functional urology. And we have an exciting roundtable planned for tomorrow. And I'll probably start by asking, maybe Sanjay, so in urology practice, what sort of patients do you see where you suspect that there may be a neurological cause lurking in the background that you might be missing?
So I guess you could look at this in various different ways. So one is situations where patients come to us primarily with lower tract symptoms and there is no clear underlying neurological condition that you are aware of, but they fall in a slightly higher risk category. So let's say somebody is in their 70s or 80s, or there are certain clinical clues to suggest that there might be an underlying neurological condition. They've had, say, some injury in the past to their back, but they don't have overt neurological problems. You're not really sure that there's a background neurological condition, but you think that there might be. That's one kind of a situation. The other is where there is an overt neurological condition, but you're not sure whether the lower tract symptoms are really related causally to the neurological condition. But to answer your question, I think the only way to approach this is to approach every functional urology patient as a potential neurourological patient, because that's the only way that we would not miss an underlying condition, isn't it?
That's right, and there are some neurological conditions that we know can present initially to a continent specialist. I mean, for example, Marcus, you'll be talking about multiple system atrophy, and what's been your experience in that condition?
Well, actually, it's precisely like Sanjay was describing. It's a person that's come along and has seen a couple of urologists. He's a man who's in his, well, he must have seen them when he was in his 30s. He'd got voiding symptoms, and they'd proceeded to TURP, doing a bladder neck followed by a TURP, so 2 operations. And they'd just not really had the alarm bell ringing at the back of their mind that, hang on, this is a young man. Like, we need to be really questioning, why has this suddenly become a problem? And there's a key word is, of course, it's a significant change in a relatively short length of time. We should really be questioning, why is that happening? Our urological conditions tend to be rather slow in onset. So if it's a sudden change in a relatively young man, think. So the multiple system atrophy question in particular is a very important one for the sort of guy. We saw this man who'd had 2 operations, and I was very unhappy that he'd had 2 operations and yet still had severe symptoms. We'd clearly not explained the problem. So a valuable question when it comes to neurourology is erectile dysfunction. So I asked him about erectile dysfunction, and he rather embarrassedly said, yes, before his urinary symptoms, erectile dysfunction. And then you're in a very strong erectile, lower urinary tract symptoms, both storage and voiding, relatively sudden onset, right age group, multiple system atrophy. Now, I'm not in a position to diagnose that. I am a urologist, but it's very easy to refer. So I would refer to neurology with a question mark. I'm worried about this guy. Do you think that there could be something neurological? And then the neurologist, well, in this man's case, said multiple system atrophy, confirmed the diagnosis. Alternatively, there might have been nothing neurologically wrong, in which case the letter would say, well, actually, we didn't find anything. I was happy to reassure him. Well, that's not bad, is it? It's like great news for the guy. It's not a humiliation if you refer somebody with a question mark and the response you get, well, thank you for checking. Actually, it's okay. That's good. That's good medicine. That's a good use of referral, even if the result was no finding.
I mean, it sounds like there are some emerging themes here that, as a urologist, you're thinking are something outside the box. You know, is it that it's something neurological? We've touched upon age. We've touched about the severity of urinary symptoms, the rather sudden onset or recent onset, but also multi-pelvic visceral involvement. So not just LUT dysfunction, but sexual dysfunction, and bowel dysfunction. One symptom I find particularly helpful is problems with ejaculation, because erectile dysfunction is ubiquitous, isn't it, beyond a certain age, and then you struggle with the psychogenic, vascular, neurogenic, but ejaculatory problems, if the man hasn't had any medications that can sort of cause poor ejaculation or hasn't had surgery, that would be neurological to prove otherwise. Age is also interesting because, we tend to assume that neurological conditions can present initially with bladder problems towards the older age group. So MSA, we've touched upon, normal pressure hydrocephalus, small vessel disease, but the young man or woman with LUTS can also present to a clinic, for example, spina bifida occulta, for example. And do you see spina bifida occulta very often in your clinics, presenting primarily to yourselves rather than to a neurosurgeon?
So I think it's not uncommon to find it, and it's not uncommon to find some minor spine abnormalities if you do an MRI on an individual. And I think the challenge here is to correlate whether the abnormality that you're seeing in the spine is responsible for the unitract symptoms that you are seeing. And in many of those situations, doing a video urodynamics from a urologist's perspective can actually help us resolve whether the problem is related to the underlying neurological condition or is not. But the one condition where even video urodynamics actually fails is the normal pressure hydrocephalus. So when you're looking at overactive bladder symptoms in an elderly individual, I sometimes find it difficult to decide which are the patients who should be referred to you as a neurologist, for instance, to screen for normal pressure hydrocephalus, and which are the patients not. Because several of the other constellation of symptoms that accompany normal pressure hydrocephalus are often found in the older individual. So I think that is an important area of problem, so to say, for the clinical functional urologist.
I'll add there, saying that that as age advances, the prevalence increases, but there's this overlap between normal with hydrocephalus in general, with small vessel disease, and so someone in their 50s, for example, it's around 5 to 10% is incidence of small vessel disease, but by around 90, around 100% will have. And so you have the overlap of multiple cerebral pathologies that can contribute to a syndrome of an overactive bladder, which is rather non-specific. And I can see where you're coming from, because I think a urodynamics is not going to give you any indicator. Yeah. And it's going back and actually watching the patient as they come to your consulting room, see how they walk, see if they need a stick when they walk, or if they have a little bit of problem with balance. It's actually, when do they take the history, are they providing it? Is it the carer, the spouse is providing it? Or are they getting the dates muddled? It might be subtle bits of your history that you might find interesting. For spina bifida, what I often find is that one leg is thinner than the other, for example. So when you have the patient in front of you for your urological examination, and you know that one foot is smaller than the other, or maybe the patient might say they're having a different shoe size, one and the other, those subtle signs might be a giveaway. But Marcus, the issue about NP of normal pressure hydrocephalus, I think is a problem that urologists across face. Your experience, is there anything that you find useful in the elderly patient who presents to you with overactive bladder symptoms that makes you feel that, this could be neurological and I need to probably investigate something cerebral?
I think we miss the point very, very often. An older man turning up with urinary symptoms, common as anything, but you really need to be questioning if there's a memory impairment present, then you're probably dealing, in my view, with a cerebral mechanism, until proven otherwise. The challenge comes with the fact that they often hide the memory impairment very effectively. So, you're saying getting the dates wrong. Well, the only way that you will know that they've got the dates wrong will be, as you said, if their partner is sat there disagreeing with them. No, it was 10 years ago or something like that. If that happens 2 or 3 times, then you've virtually nailed a problem, and they definitely need to be moved on. The normal pressure hydrocephalus, if they're walking in a funny way, don't ignore people walking in a funny way. Gait impairment, memory impairment, and storage symptoms, again, it's a high trigger.
So I have a question for you, Marcus. How easy is it for the average urologist, so I'm not talking of somebody like you, but for the average urologist to actually pick up these skills and incorporate them into practice so that they don't miss a potentially correctable problem?
Well, I think it's more about empowering people. I don't think it's taught well. We really ought to be taught. If something just seems wrong, ask whether there is something different from what you've been taught within urology. And if you see somebody walking funny, we all notice somebody walking a bit funny, don't ignore it. If there's no previous diagnosis to explain it, well, you seem to be walking a little bit strangely, what's going on there? They'll simply say, yeah, a couple of years ago my friend started to say such and such. Then you really should pursue it. Let's empower our community to say, hey, wake up.
So, Jalesh, would you say that gait is the key for the functional urologist in many of these patients, that the fact that there's a problem with the gait can actually help us identify many of the other neurourological conditions in the older individual?
I think gait is particularly noticeable because when you're sat at your desk and the patient's walking in, I mean, your consultation's actually already started, and it's far more easier to observe that because you won't be getting the patient to write, and otherwise the patient is just passively just following instructions. So I think it's handy in a consultation, but I think one important message is that we're not trying to make urologists neurologists, and is that we're not going back to medical school and say, well, look, examine the cranial nerves, do the reflexes. A lot of it is observations that as medics, as physicians, or as clinicians in general, we over years observe patients, and it's just watching how they come in, it's listening to their voice, shaking their hand,
yes,
talking
so
to the carer.
shaking. If they're looking at their hand as instead of your eye,
yes,
then they probably actually don't know exactly where their hand is.
Yes.
So notice this stuff.
And how it shakes and the grip of the handshake. Are they sweating more? They're sweating less. So it's the simple things that actually will then, and a bit of it is intuitive. I think and it's a bit implicit. But as you pointed out rightly, if something's not right, you should make a note that something's not right, and you should probably have a low threshold to involve your neurological colleagues, particularly in these groups. And I think it's the extremes of ages. So the young group, in their 20s, they've crossed the growth spurt. They have a tethered cord, they present now with spina bifida occulta and LUTS, or the elderly group where they develop some sort of pathology, cerebral, subcortical, which is once again gradually progressive, where you suspect that.
Spina bifida occulta is an important one, obviously, but we mustn't obsess about it. So We've only mentioned it. And one of the most interesting things that I've found now that I've gone to London is the relationship with neurosurgeons who've started asking me, I have a patient with a Tarlov cyst. Is it important? Yeah, so Tarlov cyst is a cyst at the base of the spinal canal. It can involve the cauda equina roots, but usually it doesn't, and usually it's fine. And if it's not too bad, they don't want to operate on it. If it's having no consequential effects, leave it alone, just follow it up. But if you see a patient who's got LUTS, and then you look at because this has happened to me, you look at an MRI scan that they've had and there's a report saying Tarlov cyst, then you're actually dealing with a cyst that's next to the nerves that supply the bladder, the bowel, and the sexual organs. So you really absolutely have to say, what's your bladder like, or urinary tract like? What's your erectile function and female sexual function, if applicable, like? And bowel control. And as soon as you start to get any positive messages on that one, the Tarlov cyst could actually be important instead of just an incidentally noted thing on a scan somewhere. So lots and lots cysts shift in the relationship between the vertebrae, spondylolisthesis, the emergence of sticky out spikes of bone into nerve root areas and things like that. This is the range of the spinal influence is actually a very mixed bag, well beyond spina bifida occulta.
We think about even lumbar canal stenosis, a very common diagnosis,
yes.
And you see, and the report says, well, it's touching the sacral root, but it's not compressing.
Yes.
And then you struggle. What does this mean? And in addition, like, as a neurologist, we do pelvic neurophysiology, nerve conduction EMGs, and we can actually study the sacral root distributions. And so it's quite helpful in those situations. And as you point out, correlate that with the bladder and the bowel sexual dysfunction, because this is a group of patients who will have comorbidities like an enlarged prostate or maybe prolapse. And I think what the neurosurgeons would like to know is how much of it is primary pelvic, how much of it is neurological.
And we don't know. And if we go and do something interventional, they could go into retention or become completely incontinent. So you've got to be so careful.
That's right.
Yes,
no,
yes.
it's
there is enough. There is potential for harm when they intervene.
You
Yeah.
can't
No,
You have to be very careful.
Oh, yes.
Absolutely.
Well, I think at tomorrow's session, I think we'll be touching upon these. Plus, I think we're going to be having some tips to the general urologist on when to suspect, and some screening questions. And there's some excellent publications that come out. Do you just want to tell us about the work from the ICS?
So the ICS did a consensus document that Holly Roy led. So it's Roy et al., R-O-Y, which was basically a group of experts who suggested various conditions that may be contributory, coming down to a hardcore of 5 different, including NPH, multiple system atrophy, multiple sclerosis, and spinal conditions. So that's a nice, succinct publication in which you can get a bit of confidence in it. It's quite an interesting one as well, because the suggestion from the working group there was not to do imaging. In other words, a urologist requesting imaging is rather likely to scan the wrong bit, or get the wrong protocol, or whatever it is. It's very helpful if the neurologist can suggest what should be scanned. But then there was another discussion at the International Consultation on Incontinence Research Society that suggested, well, some systems you will need to do the scan as a urologist. So it's local dependent. But yeah, the ICS consensus is an excellent document on which to base things.
Absolutely.
Well, I think that's an excellent way to end this session, as I'm really excited about how we're going to do this roundtable tomorrow and the feedback from the audience. But thank you very much.
It's going to be fun.
Thank you.
you.
Thanks, Jalesh.